So we're going to talk about interrupting CPR or stopping CPR. While we're performing high-quality BLS, it is vital that we do not stop compressions for more than 10 seconds. And this is for any reason, whether it's changing compressors, whether it's performing a defibrillation, whether we're moving a patient. We want to keep that goal of that 10 seconds because it takes a lot of time to get the cerebral perfusion pressure and the coronary perfusion pressure back up after it's dropped, after 10 seconds, and that perfusion has dropped. It takes a longer time to get that back up to a normal level of perfusion. If there are not paramedics available at your scene or in your EMS system, you want to begin transport to a local hospital. Consider requesting a paramedic intercept en route to the hospital. One of the things you have to look for with this is, are you going, is there a paramedic between you and the hospital? Can you intercept with them? How far are you from your hospital? There's a lot of variables to look at. But one of the things that's very important is at the BLS level, you're going to want to, without advanced life support, without a paramedic available, you're going to want to transport that patient. You don't want to sit and wait for a paramedic. If a paramedic is dispatched at the same time you are, they can meet you en route and get on your truck during the transport. And the same concept holds true for calling helicopters as well. Most helicopter agencies are not able to do CPR because of the way the helicopter is designed. They're not able to do CPR, especially on adults inside the helicopter. So again, we never want to sit and wait for someone to get to us. We just want to transport to the hospital. And then if someone can meet us en route, then that's a viable option. Chest compression fraction is something that many agencies don't talk about a lot. Very high-performing agencies look at chest compression fraction on a regular basis. And the chest compression fraction is simply the total amount of time during a resuscitation that compressions are being performed. So it's looking at how much time is our compressions being stopped. So, are we stopping to check pulses, for example, which isn't suggested anymore? Are we stopping too long to move patients? Are we taking too long to defibrillate? Are we taking too long to switch compressors? Those sorts of things. Our goal for the American Heart Association is 60% of the time we should be doing compressions, and 80% is often achievable. And you might be very surprised to look at data that we collect, that I actually collect from our agency, and many times we're over that 60%, but sometimes we're not. And again, it depends on the situation that is presented. Automated CPR devices help with this chest compression fraction, simply because, again, you don't have to switch compressors. You can use them while their patient's being moved. So another advantage of the automated CPR devices is the higher chest compression fraction that's possible. So we're going to look at some cases when you should not start CPR. So first of all, if the scene is not safe, obviously, as we will go through later in the class with patient assessment, the first thing you're going to check for is scene safety, and continually checking for scene safety as well. So if the scene is not safe, we're not going into it. If there are obvious signs of death that are present, and there's numerous obvious signs of death, and so here's a really brief description of these, and again, you'll see these throughout the course and later on as well. So first is rigor mortis, or stiffening of the body. This is typically early in the after death. The joints begin to stiffen. So if you raise an arm, for example, the wrist doesn't flex, the hands and fingers don't flex, the elbow doesn't flex, and it's difficult to, for example, move the shoulder. Dependent lividity is also called livor mortis, and this is where blood, after the heart is stopped, blood will pool by gravity. So wherever the patient is lying, the blood will, by gravity, pool in the lower areas of the body, wherever, in whatever position they're lying in. So for example, with this picture, you see this is on the back of the patient. You can see up toward the shoulder blades. There is less blood pooled. It's more yellow and lighter. That's because the shoulder blades are typically against the surface of the floor, the bed, or wherever this person was lying. And then you see down towards the lower back, which is typically curved and is not lying flat on the lower surface. There's more blood. It's darker, and there's more blood there. And then you see further down the hips and the buttocks, which is, again, typically against the floor, and there's little to no blood there as well. There's also decomposition of the body. Anytime the body begins to decompose, they've been dead for a long time. So it is important that we be able to recognize that and that we do not start resuscitation in that case. Anytime there's evidence of non-survivable injuries, such as decapitation, so this is when someone's head is no longer attached to their body, or the patient is burned beyond recognition. And there's some other cases as well, but these are some of the most common types of injuries where they're not going to be survivable. You may also have patients that have do not resuscitate or DNR orders or physician order for scope of treatment or post orders. The Indiana State Department of Health several years ago replaced DNR orders with the physician order for scope of practice. The physician order for scope of treatment or post. However, they did not make any of the former DNRs invalid. So any of the older DNRs that were still valid, that were signed properly, are still in force. So for a long time, we will see these older DNRs, and we will begin to see the post forms as well. All of these forms can be complicated. Obviously, EMS personnel are not trained as attorneys. When in doubt, you want to start CPR, but it's important, especially the post form, that you understand what it looks like, and also some of the older DNR forms, understand what they look like, so that you will recognize them when you're presented with them. So if you have already started CPR, the question often comes up, when do I stop CPR? So there is an acronym, and we've talked about acronyms before, and we use a lot of acronyms in EMS. They help us remember things. So this is the STOP acronym. So the S is for if the patient starts breathing and has a pulse, you would stop CPR. The T is if the patient is transferred to another provider of equal or higher level of training. So for example, as an EMT, you transfer that patient to a paramedic, to the hospital, or some other form of higher level provider. The O, you're out of strength, you physically are unable to continue. This might be a case if you are alone with the patient, such as you and someone are out hunting, for example, and the other person has a cardiac arrest. You provide CPR as long as you possibly can, but you're physically unable to continue. And there's no cell phone service, there's nobody around to help. So that's just simply a personal decision that you will have to make at that time, which how much longer can you go on. And then the P stands for if a physician directs you to discontinue. And this is typically between the patient getting a pulse back and breathing, and the physician directing you to discontinue is probably two of the more common things that you will see. So if you're in an EMS system that has a protocol to call medical control, you could get an order to stop that resuscitation. So next we'll look at foreign body airway obstruction in adults. In adults, typically airway obstructions are caused during meals. It's typically food that gets stuck in the airway. If they are unable to inhale and exchange air, leave these, let me go back. If they are able to inhale and exchange air, you leave these patients alone, but watch them carefully. The body has natural abilities to try to fix things. So one of those is by coughing and gagging. If they can cough forcefully, they're getting air in. In order to cough, you must forcefully exhale air out. So if they're able to cough forcefully, they're getting enough air in to cough. So let their body try to relieve that airway obstruction, but you do want to watch them closely. If they are conscious, you want to perform abdominal thrusts. And you see this picture here where you're going to stand behind them, and on the abdomen, you're going to, with an inward-upward thrust, basically you're creating an artificial cough with this. So you're going to perform those abdominal thrusts. If the victim is too large, is obese, or is pregnant, you want to perform chest thrusts. So this would be the same location that you would perform chest compressions, right in the center of the chest and the lower half of the breastbone. You're going to provide chest thrust. This is a lot more difficult because you are pushing or pulling against the sternum and the ribs and that sort of thing. So this is more difficult, but it's the only way for you to be able to relieve that obstruction as long as they are conscious. If the adult is unresponsive, we're going to check for breathing and a pulse, just like we would at the beginning of BLS. If there's no breathing, we're going to attempt ventilation. If 2 attempts do not produce visible chest rise, we're going to perform 30 chest compressions, then open the airway and look in the mouth. So if a patient, for example, has choked on food, especially if that's been witnessed, and when you arrive, they are not breathing. Excuse me. When you arrive, they're not breathing. We're going to attempt to breathe. If we can't, we're going to try to give 2 ventilations, looking for visible chest rise, and then perform 30 chest compressions, and then we're going to open the airway and look inside the mouth. If an object is visible, carefully remove it. However, never do a blind finger sweep. After this, we're going to attempt ventilation again. If not successful, continue the process of 30 chest compressions and 2 ventilation attempts. Repeat until the object comes out or the patient loses their pulse. So if after the first set of 30 chest compressions you do not get the object out, you're going to continue those 30 compressions, 2 ventilations, then looking in the mouth, seeing if anything's there. If it is, you can reach in and pull it out. Again, we never do a blind finger sweep. Airway obstructions in children, if they're responsive, you're going to perform abdominal thrusts. This probably will require you to get down on one or both knees to get down to their level, but it's the same process as the adult. If they're unresponsive and older than 1, we're going to manage them as an adult. So the process that we just talked about. If they're under 1, they are an infant. And so if they're responsive, we're going to support the child with our forearm and hand with the child's head lower than the torso. That's very important that the child's head is much lower or is lower than the torso. So you want to support that child, put your forearm on your leg as you're sitting down. You're going to perform a series of back slaps and chest thrusts. So we're going to do 5 back slaps, turn the child over, and do 5 chest thrusts or 5 chest compressions. If they are unresponsive or if they go unresponsive, we're going to begin chest compressions. Do not check for a pulse before beginning compressions. After 30 compressions, open the airway, look in the mouth. Again, this should sound very similar to the adult. You're going to remove an object if it's seen. We never do blind finger sweeps. And then we resume chest compressions if no object is seen. And we repeat this process until we're able to ventilate the patient. A few special circumstances here that you may run into. Opioid overdoses are obviously very prevalent now. What's important with opiate overdoses is that remembering or knowing that the opiates work in the brain and they will depress our breathing process. So the breathing reflex occurs in the brain. The opiates work in the brain. So the opiates will depress our ability to breathe. Once a patient is not breathing for a short period of time, their heart will stop. So it is very important that you treat the patient for whatever symptoms they're having. So for example, if they still have a pulse, but they're not breathing, we're going to provide ventilations first. And then if we have naloxone, we can give naloxone. And we'll talk a lot about that in pharmacology. If the patient does not have a pulse, then we need to start compressions. We need to start CPR. And naloxone is not indicated for BLS providers during a cardiac arrest. So it doesn't matter how much naloxone you might decide to give this patient, no amount of naloxone is going to restart that non-beating heart. So at that point, they need good, high-quality BLS at that point. Cardiac arrest in pregnancy can be very tricky. The priority is to provide high-quality CPR and relieve the pressure off the aorta and the vena cava. This is done by turning the patient slightly to the left side. This can only be done when using an automated CPR device. So again, here's another example. It's rarely needed, but it's a good example of when automated CPR devices may be advantageous. If you don't have an automated CPR device, you can have another EMT displace the uterus or slightly push the uterus to the left side while others are performing high-quality CPR. And what this does is we'll talk about this when we talk about anatomy. The vena cava, which it brings blood back to the heart from the rest of the body, is on the actually lies on the left side of the sternum, and so we want and that goes all the way down to the lower part of the body. So when a pregnant patient is lying flat on their back, their uterus, which is obviously when they're pregnant is very heavy, their uterus is pushing down on the vena cava, which keeps blood from coming back to the heart. So we'll talk a lot more about that during anatomy. So it is very important as EMS evolves into the greater healthcare family that we learn to provide grief support for family members and loved ones. So if we, either during a cardiac arrest or if we have stopped a cardiac arrest, now we have family members and loved ones to talk to. So one of the things to remember is that either during the cardiac arrest or immediately following, that some individuals can become psychologically distraught from what's going on. And so that psychological crisis can become a medical crisis. So it is important that you, again, watch for scene safety, making sure that individuals from the family, just out of their grief and their psychological crisis, are not in a position to injure any of the responders. But they can also have medical events as well. They can have chest pain, they can have heart attacks, and those sorts of things from the stress. Those family members and loved ones present will remember this event in detail for the rest of their lives. So it is extremely important that we handle this in the right way. There are no do-overs for this. And so you are a vital component in what they remember and how they react to the death or the ensuing death of their loved one. It's important to keep family members informed throughout the entire resuscitation process. Preferably have someone talking to the family as to what's going on. Let them be present as long as they don't hinder the resuscitation. This has been shown in research to be a huge benefit with the grief of the family members if they can see the resuscitation. But this is only at their choice. If they do not want to see it, they should not be forced to watch. So what to do after the resuscitation is stopped in respect to the family members and loved ones. Take the family to a quiet place, preferably a private place. And this is a time when any responders that are present that don't need to be there should leave, or at least leave the residence. Use very clear language and speak in a warm, sensitive, caring manner. Again, this is very important. Not a task that most EMS personnel like to do, but it is part of our responsibility, and especially as we integrate ourselves within the greater healthcare family. You want to exhibit calm and reassuring authority, so you want to be able to talk to them calmly but professionally. Use the patient's name. Don't refer to them as the patient or him or her or that person. If their name is Joe, then use the name Joe. Use their name because it personalizes the individual to the family and gives them a little bit of sense of comfort that this individual was at least important enough for you to know their name. Use eye contact and appropriate touch. Eye contact shouldn't be a problem. You don't want to be looking around, looking down. You want to look at them in the eyes and just kind of give them the facts. If you're comfortable with touching the patient, you want to give them appropriate touch. And this is going to be very individual between the provider and the family member. So it's going to be kind of what you're comfortable with. You need to expect some sort of emotion. It's important that they are sitting down, especially if they don't know the patient is dead. It is important to sit them down because family has been known to collapse and faint when they're told this. So this way, if they're sitting down, there's less of a risk of them injuring themselves. You want to be supportive, but don't hover over them. Once the news is told to them, ask if they would like you to stay with them, if there's anything you can do for them. Again, depending on the family, answers may be different. So just be willing to provide them any assistance that you can at that point. Ask if a friend or family member can be called. Sometimes the immediate family or loved ones will want children called, brothers, sisters called. They may want clergy called. So it is important to find out if you can call anybody for them. If there are children involved, make sure that they are not ignored. It's very important. They are going to have a grieving process as well. And you want to talk to them based on their age, but you don't want to ignore them. So continued training in resuscitation skills. Research shows that CPR skills do deteriorate in a matter of months if not practiced. So this is very important. We've known for many years through research that the 2-year span that BLS cards are active. That if for people, most healthcare providers do not perform CPR on a regular basis. So if it's like any other skill, when it's not performed, you will lose it. So we know that without use, BLS skills will deteriorate in a matter of months. So continued training is necessary. It's important as a healthcare professional that you are a patient advocate. Part of our job in EMS is public education. So we need to be patient advocates at all times. And then also it's important to facilitate layperson CPR and AED training. So when these are occurring, if your agency provides these, it is important that we advertise these and that we actively facilitate lay people being trained in CPR and AED training. So if you have any questions from this chapter, write down any questions you have and bring them to the next class session.